Well, thank you. I have no disclosures relative to this talk. So I'm going to go through staging. I'm going to go through some basics and some things that are perhaps important for everybody to know here that's involved with treating cancer patients. But then I'm going to shed a little bit of light on the process, at least for lung cancer, how the stage classification came about. And I'm going to use lung cancer as an example because that's what I know the best, but really try to focus not on the details of the lung cancer staging system, but on some of the process, because I think that's relevant to people no matter what you care for. So the basics of cancer staging is based on the TNM system that I think everybody knows was really proposed by Philippe Deneau in 1953, and that's been adopted for solid organ tumors for the most part, and really continues to be kind of the basis for staging. One of the things about this, though, that I think is worth kind of keeping in the back of your mind is that it does, I think, represent kind of a theory of the mechanism of spread that was prevalent at the time, that tumors spread to lymphatics and they kind of held the tumor back for a while, and that eventually it spilled into the bloodstream, and that's when you got distant metastases. And certainly in our current era, there's still an association of nodal spread and more likely to have the patient show up with distant spread, and some of that still pans out, and that's still why we use that. But I'm not sure that the mechanism is really the correct. We have lots of data now that there are circulating tumor cells with early stage cancers, and they don't necessarily have the ability to implant and form metastases, and exactly what governs that process is under a lot of investigation. But we may revisit some of this as time goes by. So another basic concept is that of clinical staging and pathologic staging. And I think there's a little bit of confusion about that. So pathologic staging is after a surgical resection of the cancer. And it's, and that surgical resection is sampling of, local tissues that might possibly harbor some metastases. And it is combined with other clinical imaging elements and so forth. But that's pathologic staging. Clinical staging is any and all information you have prior to initiating treatment, including surgical treatment. So sometimes I see that, if someone had a surgical biopsy that wasn't really an attempt at resection, it was just a biopsy done as a staging procedure, that people say, well, there's a path report, that means it's pathologic staging. It's actually not. It's still part of clinical staging. And sometimes I think we get confused about that. So that's worth keeping in mind because I think there's confusion. There's been a lot of emphasis, at least in the surgical literature, on pathologic staging. And, I think people have felt, well, it's more accurate. You're not relying on imaging, but you've really done an exploration. You got a lot of tissues to look at. And that's fine. But, really to guide treatment planning, it's clinical stage that we have, because you don't have pathologic stage until you've already made a major decision of whether or not to operate on the patient as a first step, which in many cases isn't really the right first step. So I think clinical stage is actually very important, and in fact the staging committees have emphasized clinical stage more and are trying to emphasize that more. And there's a big push now, as I will talk about in just a minute, to document and to accurately kind of reflect clinical stage as we make decisions about patients. So a couple of key points that are important for us here in terms of treating cancer patients. You always can assign a clinical stage. All you have to do is have met the patient. You don't have to have a cancer diagnosis that's documented yet, but you have an idea what clinical stage they are. And it may be just based on a history and physical exam, and that's okay. But it's really no longer acceptable to use MX to say, well, I haven't assessed the patient for distant mets. Well, if you've met the patient, you have some idea and so you need to take a stand. I think they have distant mets. I don't think they have the distant mets, and the same for TN and M. So certainly clinical stage evolves. When you first meet a patient, you haven't done any imaging studies, you haven't done any confirmative, further imaging or biopsies or whatever, you may change your clinical stage up until the time that you say, okay, I've stopped all my workup, I've decided what I think this is, we're going to call it clinical whatever, and now we're going to proceed with a treatment plan. Up until that point, it changes. But that's okay. You still, every point you have, you can make a statement about, what you think the clinical stage is. And sometimes there's a reluctance of people to say, well, I can't assign a clinical stage because I don't know yet. I haven't confirmed this. It might change. But those are really things that, we have to just accept. So let me make a few comments about some key cancer organizations. So there are two organizations, the American Joint Commission on Cancer and the UICC, which both have worked on stage classification. They initially started out as separate organizations, and then way back in the 1970s or so, they said this doesn't make sense. We need to have the same stage classification system worldwide. We will cooperate. So they still have some slight differences, but in terms of what the official classification systems are, they really work hand in hand, and there's only one staging system that comes out. It gets revised every 7 or 8 years. The new staging manual was just released, for use starting January 1st of 2010. And these organizations are very involved with the stage classification system. There's another organization by the American College of Surgeons, the Commission on Cancer, and I think this is just sort of historically, it was the surgeons that said we need to try to organize our cancer care processes a little bit better, and what can we do about this, and so forth, and they've kind of carried this forward. It doesn't have anything specifically to do with surgery. So that group really focuses more on the process of cancer care and what sort of standards in the U.S. should be put out there in order to try to raise the bar and improve the processes. So they have done a lot of things. So they've established a national tumor registry that's been ongoing now for decades, and there's a lot of epidemiologic and other data that we have from that. They've established a system of accreditation of hospitals. Accreditation can be either basic or it can be with commendation, which is something that we would certainly like to have. They have some structural standards. You need to have a tumor board. You need to have a cancer committee, which we have. Many people here are on that cancer committee. Some activities of what the cancer committee needs to do are governed by some of their rules. And they're trying to just establish some sort of baseline bars of, this is kind of a basic thing of a good cancer center. We actually would like to be well above that baseline. We want to at least meet that baseline. They set some standards for path reporting and for staging and for tumor boards. Tumor boards need to involve prospective discussion of cases and at least 10% of the cases in the institution. And there are some quality metrics as well, which are actually, they have been collected, and they are now, some of these are starting to be publicly reported. So that's another thing that, we need to be aware of and cognizant of. So some of the standards are that clinical stage is documented in 90% of patients prior to initiation of treatment. Well, I mean, it kind of makes sense. I mean, that's a major factor in what treatment we give. And so we certainly need to know what it is. We don't always document it very well. And one of the standards that the American College of Surgeons is holding us to for our accreditation is this standard. And so it's very important that we do this. We also need to document, if we discuss a patient at tumor board, what the stage is. Now, this kind of transforms things, though. It has important implications for our tumor registry. So our tumor registry is really being transformed from a group that, 6 months later, when all the, staging and treatment and everything was done, they collected information and they reported it to the National Cancer Database and so forth. now with these, this change in focus on, clinical staging at the time treatment decisions are made, the tumor registry is having to document that and get more involved and is becoming much more real time than what they were before. So that's a challenge for us, how to meet that. That's a challenge for everybody across the country. Another thing is the public reporting of quality metrics. So there are not a lot of them at this point, but there are a few in breast and in colorectal, and there are a few that are being publicly reported. But that also is a sort of significant change for the tumor registry, because now we are responsible if a patient, had a diagnosis made here, but that ended up getting treatment as an outpatient somewhere else. We can't say, well, we don't know what happened to that patient. That patient got treated somewhere else. It's not allowable. We need to be able to say, well, that patient did actually get, these treatments according to this, metric. And so, tumor registry is forced to knowing about what happens outside of the institution as well as within the institution. And I think those are two major challenges that, we're dealing with. And so I'm just going to harp one last time on clinical staging. I think sometimes people say, well, listen, I document it. It's just that, it's not in my actual node. It's just somewhere else that's hidden. And if nobody can find it and tumor registry can't find it and the reviewers can't find it when they come and they audit our program, we look bad. And the reality is right now, we're not at that level that we need to be at. We've got a problem here. And then there's some, concerns about, listen, I don't spend a lot of time thinking about that because we're going to operate on a patient anyway. We'll figure out the stage afterwards. It really doesn't factor into our decision making. Well, that is true for a few situations. And in fact, the American College of Surgeons has said in those situations, you don't necessarily have to do this ahead of time. But those are pretty rare, and I think that we're better off to just kind of adopt this across the board. Other things that I think are not so appropriate is that, past stage is more accurate. Well, it's true, but we really base our treatment decisions on clinical stage. I'm not completely sure my clinical stage is accurate. Well, you just have to make your best estimate. Or the concern that treatment is based on other factors besides stage, which is true. But that doesn't mean that stage isn't one of the important factors, and we certainly can't ignore it. So I think we need to explicitly document this in pre-op notes and RT treatment planning notes and chemo planning notes and orders, and some of these things have been incorporated into some of the new electronic medical record screens, but it's something I think everybody needs to be aware of. And we need to make a better habit of doing this in our notes and documenting stage at tumor board discussions. And we really need to develop a system where we kind of track all new patients and update that with staging information. So now I'm going to transition a little bit from some process measures that are important for us to pay attention to locally, because we're going to be audited in a few months, and we don't look good right now, so we got to get our act together pretty quick. But I'm going to transition from that to the stage classification system. I'm going to use lung cancer as an example and kind of go through quickly some of the aspects of it, but mainly to try to illustrate what some of the way is that that's happened. So this is kind of what's happened in lung cancer. We started out with a staging system that was based on a small number of patients. The last change was made in 1997. The 2002 edition didn't actually make any changes. But here we are now in 2009 or 2010, and so, this is the number of patients that were included in the analysis compared to that, the number of countries and the number of centers and so forth. It's just dramatically different than it was before. It's largely due to the International Association of Lung Cancer having taken a lead and saying we really need to do a better job. It's about 10 or so years of work. They established a committee. A bunch of subcommittees, went through working on collecting the data, proposed some classifications, published them, had some debate about it. Finally, they were endorsed by UICC and AJCC and have been released. So that's the process that's happened in lung. So they picked, they ended up with 81,000 patients. They picked a narrow time window rather than the previous system, which was based on 5,000 patients accrued over decades, 4 decades actually. Narrow time window. And they developed a very sophisticated analysis system. So they used a regression analysis that was internally validated by using a training set and a validation set. And they also said that, if we're going to say that this group of patients is different from this group of patients, then that needs to be true in Asia as well as in North America, and for adenocarcinomas as well as for squamous cell cancers, and for various subpopulations. It wouldn't accept it if it just kind of panned out in one population, but it didn't in others. And then they also externally validated it against SEER information. So there was a lot of statistical analysis that went into that. So this is really much more of a scientifically based stage classification than what we've had in the past. On the other hand, there are differences. If you look, Asia and Europe played a big role. North America actually not so much. A lot of these were from series, not too many from clinical trials. It varied a lot. The T descriptor, they did fancy statistics, decided that 2 centimeters was an important point, and 5 centimeters and 7 centimeters. So they came up with these cut points that went into the T descriptor. They went through the N descriptor as well. It did the same process of internal validation, external validation, and basically ended up saying that the node classification system, as it had been proposed many, many years earlier, based mostly on intuition, actually held up quite well and was, accepted as we're going to keep this. And this is the description for lung cancer. Again, I'm not trying to dwell on lung cancer. I'm trying to illustrate the process. And then they went through M descriptor and did the same thing, regression analysis, internal and external validation, and came up with a new classification, which wasn't just M0 or M1, but divided M1 into an M1A and an M1B. And they went through the same thing with stage grouping. One of the things you may notice on some of these slides is although they had 81,000 patients, when they actually went to do some of these analyses, they didn't have full data on all of the patients that they could use for each of these analyses. So they took what they had. But they went through the same process and came up with a somewhat newer system of grouping the patients. And if you look at survival, this is survival of the patients in the database based on the old system, the 1997 system, and based on the new system. And you can certainly see that the curves separate out much more nicely, looks much better. Well, duh, of course it does. I mean, the whole system was designed to have better separation of the curves. I mean, that's the way that they decided to do the groupings. So of course it looks better. And they've come up with a system here based on TN and M that you can illustrate in a variety of ways. This is one way, but the bottom line is that it gets to be pretty complex. There are a lot of different, kind of subgroups, and it gets to be complex. It gets to be hard to remember and hard to kind of put into practice. Certainly more complicated than it was before. Well, why is that? Well, I think in part as we have more data to work with, we start to look at differences and get more granular about things, and that's just going to make it more complex. Just simple byproduct. But I also think that some of it is that, the previous system was based heavily on just intuition, and so it kind of made sense and we could remember it. And now it's based very much on this sophisticated statistical analysis, some of which doesn't completely make sense to us. We can say, well, that's how it panned out. But and then the other thing is that I think that we expect a lot of different things from a staging system, and sometimes we get a little bit carried away about what this is supposed to do for us. So one of the things a staging classification system should do is provide a common language for communication, so that if I'm talking about a stage 2 group of patients and someone else in Frankfurt, Germany is talking about a stage 2 group of patients, that we know what we're talking about and we can communicate and we can compare results. And certainly the stage classification system accomplishes that. We'd also like to define homogeneous patient cohorts. Well, it depends a little bit on how you define homogeneous, what your purpose is, and I think we need to be a little careful with that. The stage classification system, they said, well, we're going to do homogeneous based on survival, based on what we've observed during this 10-year period across the world with all kinds of different treatments. But that's the best we can do. And I think that was a reasonable way to do it. I think that's very different for us saying, I'm going to treat a group of patients in a certain way, and I want to know, are these patients all homogeneous? And guess what? The international stage classification system doesn't quite define a homogeneous population for my particular purposes. Well, it wasn't designed to do that. You're putting extra things on there. Prognosis, I think we also have to be a little bit more careful, and I'll give you a few bits of data on that. Another thing that people often say is, well, I would like the stage classification system to give me a cookbook of how I need to treat the patients. And it really can't do that. It wasn't designed to do that. The patients that were analyzed here got a lot of different treatments, although there was some treatment data that was collected in IASLC, in the database. They really didn't focus on it. It wasn't validated, and they've said, we can't use any of our treatment data for any analyses. We just don't trust it. It's not good enough. So there are a lot of different things we'd like out of a staging system. So I think what it does is it clearly provides a common language. I don't think it defines a treatment algorithm. And I'll show you a little bit of data. The treatment was all over the map of what patients got. Treatment really needs to be designed, dictated by clinical trials. We need to consider other factors, other patient characteristics, comorbidities, lots of other characteristics. And finally, we hope that our treatment is going to evolve more quickly than the every 8-year or so revision of the stage classification system. So we really can't use it for that. And I think for homogeneous, groups, I think it depends on what we want out of it. And I think the other thing is that we have to be very careful about using the stage classification to define prognosis. So this is just the treatment. We went to the NCDB and looked at, this is a slide that Dan Boffa may have shown a couple of weeks ago, but we looked at those patients that changed from one stage to another. And a lot of people said, well, it used to be a stage whatever, and now it's a stage this, so that means that we should be treating these patients differently. Well, actually, it's not true. I mean, the treatment they got was all over the map. We can't say, well, their prognosis was such and such because they were treated in a certain way, and so therefore we ought to be doing something different. The treatment was such a mixed bag. The treatment varies all over the map in this. The other thing is when we look at just prognosis, it also varies a lot. So there were differences, for each of the groups here. There were differences between Asia, North America, and Europe, differences between series, registries, clinical trials. It's true for the T classification. It's true for the N classification. It's true for a bunch of different things. So, the way they separated it in the staging system, in the stage classification, is the differences in prognosis needed to be consistent between groups that they thought were, valid to separate in Asia, in North America, in Europe, for adenocarcinomas, within series, within clinical trials, et cetera, but it was the differences. It wasn't the actual prognosis. And so if we're going to start using actual prognosis, that we say, all right, we've got this great database, 100,000 patients, that tells me that the stage 2 lung cancer has a prognosis of 50%. Well, actually, we don't know that, because if you're really going to use that, you probably ought to say, well, wait a minute, my patient's in North America. I need to go to the North American data, and probably I should look at the, registry data and not this one clinical trial. And, you need to start looking at all those nuances. And, I don't think we can use it for prognosis. So let me talk a little bit at the last couple of minutes about prognostic factors. So that's another thing that people often bring up. Say, well, listen, we got all, we're looking at prognostic, we're doing a lot of molecular characterization of tumors. Isn't that important? Isn't that what's really going to drive it? How come the staging system doesn't include that? Well, actually, that was very well recognized by HICC and UICC and IASLC. They very much wanted to analyze that. But it's actually pretty difficult to really define robust prognostic factors. And in the end of the day, the stage classification remains anatomically based, TN&M, and they're working on trying to figure out how to integrate other factors. So the IASLC thing did do some analyses, so they looked at combining clinical staging and prognostic factors. You can see here some of the prognostic factors that they looked at: sophisticated analysis, training set, validation set, both multivariate and RPA analysis, which have some differences in what they'll pick up and what they'll show. And the bottom line is that if you look at prognosis by stage only, this is sort of a measure of how good it is. It's a little bit better if you include the full prognostic model, but it's really not that much different. Kind of a little bit surprising. And they've come up with this as an example so that, patients that are stage less than 2B are over here, and then you look at performance status and age and, various factors, and you can draw circles around various groups that, look consistent, and, they did the validation set, and it nicely separates the curves, and you can go through all of that, but, how practical is it really? I think it's not quite there. So this is another summary that they did, and certainly clinical stage panned out no matter what analyses they did. Performance status panned out fairly well in the more advanced stage non-small cell lung cancer patients and the small cell. But then when you go through the rest of them, it really only panned out in certain groups and with a lot of caveats, and it really didn't pan out as well as we might have thought. We went through the same thing with path stage, and again, training set, validation set, similar thing. Came up with this. It's a little bit different, but same kind of process, and you can, sort of pick out these various groups. Can look at it this way, that you say, well, they're stage this, but you should move them up a stage if they're greater than 70, and come up with things like that. But I don't know how practical that really is, and they didn't really think it was all that practical either. And I said, this is something that can give us some insight into things, but we don't think it's really there. So one of the problems is that a lot of studies of prognostic factors have been so-called phase 1 studies, where you just do an exploratory analysis and you figure out that, the people that drive yellow cars have better survival, and the people that put on their right shoe first do worse, and, by chance, you will find some things. And if you look at those in isolation, you can, publish a paper. But to really get a validated prognostic factor, it's much more difficult. One that actually adds something beyond stage alone, as this analysis showed and other analyses have shown, it's much more difficult. And so, although we looked at that a lot, and we think there's a lot of promise in more molecular characterization of tumors, we're not there yet. We're really not anywhere close, unfortunately. We've got a lot of work left to do. So I'm going to just finish with that. I think that, that's an exciting area, but, there's a lot of work left to do on that. There's a lot of work going on to prospectively collect things and hopefully do a better job in the future on this. So, thank you.